We are live. Howdy, everyone. Aaron Boster here. And as always, thank you for learning about MS with me. It is a beautiful Saturday. I've had a fantastic MS clinic all morning. It's just wrapping up. We have a couple infusion patients that are finishing up their afternoon. And I wanted to jump online and say hello, howdy, hi to everyone. Good afternoon. I have so enjoyed testing out different times to do live streams. We've done a couple late at night. We've done a couple early in the morning. Here we're on a Saturday afternoon. It is fantastic to see you jump online. Darla, thank you very much for joining us. Darla is one of our outstanding moderators. Cynthia is here. We've got Greenbee here. Now, as you guys log on, tell me where you're coming in from. So Aaron Reed, hello, my brother from another mother. Jump online, tell us where you're logging in from so I can see everyone. I'm going to give a few minutes for people to jump online. This is fantastic. It's Saturday afternoon. I've had a wonderful MS clinic. There's 80 of us that are jumping online as I sit at the Boster Center for MS, water in hand. I'm looking at this is fantastic. We have 86 people online. If you guys are feeling the love, set some flames in the chat. Go ahead and hit some flames and fill the whole chat with flames. Once we do that, I'll know that we are ready to start a question and answer. Ask me anything MS. All right, let's get some chat going in the flame, guys. Can we get, there we go. So Rock Chick has it, Rachel has it, Shelby knows what's going on. Candace is in the house, Monica's got it all lit up. Here we go, guys. We're going to get the whole chat full of flames. We did it. That's fantastic. Thank you. Let's rock and roll. So my name's Aaron Boster, MS neurologist in sunny Columbus, Ohio. I'm actually at the Boster Center for MS right now. Little logo action. We've wrapped up a fantastic Saturday clinic. I have to tell you, I love doing Saturday clinics. Saturday clinics are the best. It's a different pace. I think people select Saturdays very, very purposefully. It makes for a very lovely way to spend my weekend. So we've got Luke, who's here from Serbia. I had a chance to go to Serbia a couple years back. It was a phenomenal experience, amazing people. Goosehead Insurance writes in, question. My girlfriend and I were both recently diagnosed with MS, and I want to know if the new Delta variant of COVID-19 puts us in danger. We're both vaccinated. So if you have MS or if you don't have MS, your risk of contracting COVID-19 is the same. In other words, having multiple sclerosis does not increase the risk to develop or contract COVID-19. Now, if you have MS and contract COVID-19, there's no reason to think that you'll have a more severe disease outcome compared to if you didn't have MS. So having MS doesn't increase the risk to develop COVID, and it doesn't increase the risk of a more severe outcome. Unless you're immunosuppressed because of a medicine that we've given you, or unless you have very advanced multiple sclerosis. So I don't think that the Delta variant creates a new set of concerns, particularly for those that are vaccinated. If you're unvaccinated, it's a very, very different set of variables. Excellent question, very timely question. All right, so Rehab HQ writes in, I have a patient who received Ocrevus last year. She had a follow-up with her MD at Mayo, who told her she had 0 antibodies for her COVID vaccine, so she has to get a booster. Do you agree? Yes. What other questions do we have cooking here? How important is a booster vaccine for COVID, PPMS, Ocrevus? Let's talk about this. Let's talk about MS and Ocrevus, or another B-cell killer, and COVID-19 vaccines. So here's what we understand as of August 14th, 2021. If you have MS and you're taking a B-cell depleter, so Ocrevus, Rituxan, Kesimpta, ublituximab in the near term, those are B-cell depleters. Or if you're on an S1P receptor, so these are pills like Gilenya, Zeposia, Mayzent, Ponsoy, these medicines, both classes, the S1P1 receptor pills and the B-cell depleters, it looks like inhibit your ability to mount a full antibody response after receiving the COVID-19 vaccines. Now, we probably mount a beautiful T-cell response when vaccinated, but we're not seeing a full B-cell response. So when you vaccinate someone, it causes you to mount a T and a B-cell response against whatever you're being vaccinated about. And if you have a B cell depleter or Gilenya, one of those drugs on board, you may not mount an adequate B cell response, which is stinky. And so today we have a couple different options. One option is to come off those therapies, which is not easy to do. They don't come off quickly. It's complicated to come off in some respects. And we're using the therapies because we're treating MS. And so we're looking for other ways of trying to game this out. Another thing that you can do, which is extremely effective, is to throw a mask on. And so if you're on a B cell depleter, or if you're on a Gilenya-like pill, wearing a mask around others in public, outside and inside, is a really smart idea. And I would 100% recommend that. A third thing that we could do is we could boost your immune response by giving you a third vaccine. And the CDC recently came out and said that was a good idea, and I agree. And so if you have MS and you are on a B cell depleter, or if you're on a Gilenya-like product, then I think it's very, very reasonable to get a third vaccine. Here in Ohio, I'm not exactly sure how that's rolling out, but it's something that I'm definitely encouraging for my patients. So that was a great question. Thank you guys for asking it. Very, very timely questions. We've got some people here from Virginia that are logged on. I've got a question from Miss D who writes, "Hi, Doc. Thank you for making these great live streams." Well, D, you're welcome. It's really fun for me. It's an awesome opportunity to interact with you and to interact with this global growing online community. So I really get a lot out of it. It fills a bucket for me. It's also an opportunity to educate and energize and empower people impacted by MS all around the globe. And I get to do that even though I don't get to meet you. And so that's a special moment for me. So she writes, "I have a question. How do spasms in the legs and feet occur? I have no lesions in my spinal cord, but 14 in the brain, 1 lesion in the pons." So Miss D brings up a good point. If you have a spasm or a cramp in your foot or in your leg, let's say, what's happening is the muscles are not playing nicely together. So we'll use my arm because I don't want to drag my leg up on camera. So we use my arm here. If I want to bring my arm like this, the bicep muscle has to get shorter and the tricep muscle has to relax. The tricep has to relax so it can stretch out so that my arm can bend in. And I don't say bicep contract, tricep relax. I just bring the water to my face, right? And the tricep relaxes because it's told to relax by the spinal cord and the brain. So there are descending motor pathways that start in the noggin, go through the brain, through the spinal cord, and then they leave the nerves and they feed the muscles. So if you've had damage to the brain or the spinal cord, all right, so that was important. You could have damage to the brain or the spinal cord, either one, then it can cause spasticity. It doesn't just have to be in the spine. We can see spasticity because of brain lesions, and we do very, very often. And so any damage along that descending pathway can cause spasticity. Good question. So Ellen says, Dr. B, question, is there new symptoms of extreme dry mouth, something to investigate? How? So you can have dry mouth for a lot of reasons. It's not very common. In fact, I would say it's not an MS symptom per se, although very commonly it's a side effect of medicines. So definitely want to look into dry mouth. There's something called SICA, S-I-C-C-A, SICA syndrome, where people have dry mouth and dry eyes. And that's seen in the setting of another autoimmune condition called Sjogren's syndrome. And so it's worth looking into. Iris from Gibraltar has got on. So Iris, it's great to connect with you. Iris and I have tried to connect on live streams now for 4 or 5 live streams and it hasn't worked. And so we have found a time. It is almost 2000 in Europe, where Iris is calling in from. And here it's 2 o'clock in the afternoon Eastern Standard Time. And we finally made it work. Go us. So Brianna says, can Ocrevus patients get the booster? Yes, yes, yes. I want you to get the booster. All right, so let's see what other questions are here. This is fantastic. Should I be giving my kids aged 21 and 10 extra vitamin D? Or is there anything I can do to lessen the risk of MS? Yes, that is a really good question. So if you have a first-degree relative, that first-degree relative has an increased risk of MS because you have MS. So if I use statistics in Ohio, the average Ohioan's risk of getting MS is about 1 in 350. And in first-degree relatives of someone with MS, it's 1 in 40. And the question is, is there anything that we can do to lower your children's risk? And the answer is yes. Number one, you can make sure that they don't smoke cigarettes and they're not exposed to secondhand smoke, because smoking doubles the risk to develop MS. That's very serious. Now, number two, you can make sure that their vitamin D 25-OH level is above 50. If it's above 50, that's going to lower their risk. Number three, you can make sure that they're not morbidly obese and have an inactive lifestyle, because that's been shown to double the risk for MS. So keeping your kids physically active and not morbidly obese, making sure that they have a high level of vitamin D 25-OH, and making sure they don't smoke. Those are things that we can do to lower a child's risk of MS. Matt Z is on. What's up, Matt? It's great to see you. Matt's one of our awesome moderators. Thank you very much for your help today. So let's see what else we have cooking. Jen McGraw is on. Hey, Dr. Boster. Hey, Jen. If vaccinated earlier in the year and about to start Ocrevus, should we have a third vaccine before issuing the infusion? So if you did that, it would be ideal. And if you didn't do that, getting it about a month prior to your 6-month infusion would still be early enough in the lifespan of Ocrevus that we would expect it to have an effect. But to be clear, yes, if you could do all 3 shots, so the booster, the third vaccine prior to starting a DMT, specifically Ocrevus, that would be very helpful. Yes. Faith writes in, undiagnosed, still have had several MRIs, no lesions, a multitude of symptoms. What should I do when a flare is struggling to cope? And that stinks. And so sometimes a human can experience neurological symptoms and we can't figure out why. And we get MRIs and we do lumbar punctures, and we do testing, and we can't figure it out. And so in that situation, if there's a high index of suspicion for MS, we'll do serial MRIs. I typically do serial MRIs every 6 months for about 2 to 3 years. Then I go to every year for 2 to 3 years, and then I may back off. During that time, if you're having new symptoms, I want you to jot them down, all right, so that you can bring them to the attention of whichever clinician is monitoring you. And if it's a visual thing, maybe film it, like get your phone out and film it so that you can then show the doc, hey, here's what I've been seeing. So try that out. It is frustrating, and I'm sorry that you're going through that, but I hope that you've got someone who can monitor and make sure that nothing evolves, or if something does evolve, they catch it right away. So Cynthia, flames. Yeah, so Cynthia's got some flames going on. It's great to see you, Cynthia. Donald Duck writes in, what are the known COVID vaccine side effects for MS? Got 2 shots yesterday. Today I'm back in leg pain. I haven't experienced in weeks. So I do think it's fair that when you get a vaccine, you can see an uptick of neurological symptoms from MS transiently, and then it should die back down. Why? Because you're triggering your immune response to get all riled up. You may have a fever as a response, and you can, in the setting of MS, short circuit. Now, not forever, but just for a little bit. And so it's not uncommon that when patients with MS have a COVID vaccine, they may notice a little something, a pseudo exacerbation, where an old numbness comes back out and says hi and then goes back away. Or maybe they have a little double vision for a while, they haven't had in a while, then it goes away. And that's not fun at all. But the risk benefit, I still think, is strongly in favor of getting vaccinated. So Kevin Everhart writes, what does it mean when T2 lesions on last year's MRI are now T1 or black holes on this year's MRI? It means that the area of inflammation seen last year in the bright spot was so intense that it ate away at the tissue. And this year, you see the residual hole that was left where the inflammation occurred. Now, all people impacted by MS have black holes. And the ratio we keep in mind is about 10 to 1. So for every 10 white spots, it would be okay to have 1 black spot. I get very nervous when I see that the ratio is close to 1 and 2. So 1 black spot for every 2 white spots, that's a bad sign. So Jennifer writes, MS caused fat atrophy. I have a rather large indent in my thigh. My MRI shows atrophy of the fat, but it says it's likely due to trauma. So no, MS does not cause lipoatrophy the way that you're describing. Now, injecting with MS medicines can. So if you inject insulin, or if you inject Copaxone or Avonex into your thigh, then over time, the subcutaneous fat tissue can be eaten away. So that definitely can happen. This is awesome, guys. We have 153 people online. There's only 52 thumbs up. So if you guys like what we're doing, leave the chat, hit a thumbs up, and jump back in. And let's see if we can push that thumbs up upwards of 100. It helps out the analytics on the channel, and it tells me that you love what we're doing. And so if you don't mind, go ahead and throw a thumbs up in there and let me know that you're digging this. Grateful Being writes in, how about IVIG in COVID vaccine? I had my last Rituxan in March. I was also on methotrexate, which I stopped when I found out that I had liver disease. Started IVIG this week for super low IgG. Very, very complicated situation. So here's someone we're assuming has MS because this is an MS live stream. And we're assuming that they were on Rituxan for MS. They've come off Rituxan, and now they're taking IVIG. And so I don't think the IVIG would necessarily interfere with the vaccine, but ideally you'd want to kind of space them out. The farther away from the Rituxan, the better, as it relates to successfully having an uptick of the immune response after the COVID vaccine. And if I had my druthers, I would probably try to do a vaccination and then wait a month before I did my next IVIG. That would be the ideal. It is a tricky situation, and you're really grappling with multiple different variables. Jess writes in, good vibes only. Jess says, I can't get a diagnosis even though I have symptoms and my eye doctor says I have MS. What do I do? Then you find a different neurologist. You have someone that does proper MRIs, lumbar puncture, etc. I have several videos on the channel about how do you work up MS, how do you diagnose it. You need to find someone that'll help do that with you. There's 119 thumbs up. That makes me feel sensational. Thank you, guys. Let's get caught up with some questions. So Kristen Sandra, I'm sorry if I said your name wrong, is showing some lovely water, and I'm digging that MS water challenge. Go ahead and drink up, guys. Peppa writes, hey, Dr. B, MS and possible Behçet's. Need outside of the box thinker, doctor to oversee all. Do you do Zoom consultations? I do have lovely providers, but need more. Well, Peppa, it's nice to meet you. Howdy, hi. Yes, I do some Zoom consultations. And during this global viral pandemic, I was doing a lot of Zoom consultations in Ohio, where I practice, outside of Ohio, in other states, and even in other countries. And now that the rules are starting to be rolled back, we're going to tighten that up a little bit. So I think where things stand right now, if you want a second opinion and you're in another state or another country with no plans of coming to the Boster Center long-term for your care, we can do that. But it may be a one and done where I see you in consultation, answer a question and stop. If you want to be followed long-term, we're probably ultimately going to need you to come to the Boster Center once or twice a year. And so as we onboard new patients, we're asking them those questions. Is this a, hey, help me out, give me some guidelines and put together a plan that I can give to your doctors that they can look at? Or is the desire to have a long-term ongoing care? And if that's the case, we can do that, but you may have to travel to sunny Columbus, Ohio once or twice a year, and then everything else we can do on telemedicine. Very good question. Peppa, you've got some flames in there. Would everyone else join Peppa in flaming up the chat? I'd love to see that. It's super, super fun, and it helps the analytics. Go ahead and flame up the chat for me, guys. Once we get flames all the way across the chat, then I'll jump into some more questions. So in the meantime, we'll do a little MS water challenge. Lena H. from Sweden says hi, hello in Sweden. Go ahead and flame up the chat, guys. Rachel's got it. Jen's helping out. Donald Duck is full of flames. Lane and Corey got it going on. Raging Skies and Jess, good vibes only. Thank you, guys. Let's get the whole thing filled up with flames. Oh, yeah. So we've got TV DB who's flaming it up. Oh, this is super duper. All right, we did it, guys. Thank you very, very much. Now let's jump into some more questions. Look at it. That's really, really fun. Now, Matt is helping out by copying and pasting some questions. It makes it easier for me to see them. I really appreciate when the moderators do that because it's hard for me to follow the stream sometimes. So he's queued up a question here from BJ, who writes, my doctor put me on Kesimpta without any information and follow-up. What should be done? So I think that it starts with calling the doctor's office and saying like, hey, can you teach me about Kesimpta? Now, I have videos on my channel about Kesimpta, and so you can get some MS education that way. But I definitely think that you want to call your provider and be like, hey, I'm not understanding this medicine. Could we have a visit where we just kind of go over it all, make sure I know which labs that you want me to get, make sure I know about what I need to be thinking about with COVID vaccines and what I need to be thinking about safety, et cetera, et cetera. So I think we would start with an updated combo. That was a good question. So Matt's copied another question for me. Thank you, Matt. And this question is from Kate Servey Q. Ophthalmologist told me if my good eye is acting up, they can't tell until it's the same or worse as my bad eye from optic neuritis. Can you explain this? So that's not exactly 100% true, but I think I understand what they're talking about. So when we do the eye pupil test and we shine a light in this eye, and then we swing it over to this eye. So you may be sitting in a dark room with your neurologist or ophthalmologist, and they're sitting there doing what's called a swing test. What they're doing is they're seeing how your pupil behaves. And if you've had optic neuritis in this eye, but not in this eye, when we shine a light in this eye, it's going to do something weird. It's called an afferent pupillary defect. So that's a lot of doctor words, which tells us this pupil's goofy as compared to the good pupil. That's the point, is that it's a relative change. It's relative to the good eye. So if this is your bad eye and this is your good eye on this test is going to look good compared to the bad eye. And if the good eye starts to tank, it starts to do poorly, that one test may not be as accurate because, again, you're comparing this eye against another eye. So I said the word eye too many times. Suffice to say that this one particular test, that can be challenging, but there are other ways of diagnosing. So using the OCT machine, that's going to tell you whether the good eye is having more problems. Doing visual evoke potentials, that's going to tell you if the good eye is having more problems. So there's more that can be done to sort that out. I hope that made sense. If I try to say it again really quickly, the physical exam finding of an abnormal pupil is contingent on the other eye being normal. So if the good eye becomes bad, it messes up our ability to interpret. And that's, I think, what they were trying to say. Woo! That took a lot of words. Maybe have a little water. What is your view on famotidine? Allison Burnett asked me. I think famotidine or Ampera or formamidine, it's all the same thing, is a really, really good compound. I think that it's a very powerful tool in helping people navigate the heat and navigate exercise and motor fatigue. Ampera or Fampira. Ampera is a twice-a-day medicine. It's a prescription medicine for a very specific symptom in MS, and that's motor fatigue and heat sensitivity. So if you go outside in Ohio in August and get overheated, and as a result, your nervous system short circuits, you go blind again, or your legs get weak again, or your whole body gets really numb again. And then once you're out of the heat, you're better. That's heat sensitivity. If you have motor fatigue, that means you're out strutting your stuff, walking, doing your groove thing. But after a while, your legs become weak, and then you have to rest before you can do it again. That's motor fatigue. And those two things can be amenable to Ampera. Now, only about a half to two-thirds of patients respond to Ampera, and we typically give it to people for a month before we can figure that out. And if you've had a seizure disorder, Ampera is a no-no drug because it can increase the risk of seizure. We also want to make sure that you have normal kidney function so that your creatinine clearance is not affected by the Ampera. But for the right people, it is an amazing drug, and it can be almost a Lazarus effect where you're like, whoa, I can't believe you didn't give this to me last year, doc. If you take it for a month and don't notice anything, typically then it didn't work. But if you have motor fatigue or heat sensitivity, I definitely think it's worthwhile to try it out. Very good drug. Now, I was involved in the clinical trials that led to its FDA approval. I've been using it even before it was approved. We used to have it compounded at pharmacies. A lot of awesome questions here. So Carolyn writes, if I had a reaction to the first dose of Ocrevus, what's the chance of having a reaction on the full dose? So the risk of a reaction with the first dose has been calculated at just under 30%. So you had a 1 in 3 chance of that happening. Every subsequent dose, the risk is 8%. So that's like less than 1 in 10 chance. So the answer to your question is a 1 in 10 chance, which is a pretty low chance. So Lisa Coates writes, does cerebellar damage from lesions ever get better, like balance, tremor, and coordination? Yes. So if you've had damage to the brain or spinal cord from MS, particularly in the balance centers, you can rehab that. By doing physical therapy, balance, and rehab, you can rehab that and make it stronger again. There's 182 people on, and I'm not sure that we've had 182 people on in quite some time. It maybe has been a year or two since we've had that many people. That's awesome. If you're just joining us, thank you. My name's Aaron Boster, and I'm an MS neurologist in sunny Columbus, Ohio. I'm actually at my clinic at the Boster Center for MS, where I had a fantastic morning seeing patients and doing some MS infusions. It was really fun. Took care of a couple patients with baclofen pumps and some other cool stuff. And we're jumping online right now, answering some questions and interacting with you guys. I love this growing global online community. This YouTube channel is so important to me and my ability to educate and empower and energize. So if you're just joining us, thank you very, very much. When you jump online, tell me where you're calling in from. It's super fun to see where everyone's coming from. Also, if you have a question, please phrase it in a way that's general. I can't really answer specifics because I don't have enough information about you as we talk on the interwebs. Also, if your question's not answered, because I can't answer all of these questions, I will answer them later. I copy them and then I typically make follow-up YouTube videos where I answer your questions. So don't feel like you got cheated. So let's take another question. So Linda Ann says, please get added to my insurance network. Well, Linda, that's awesome. If you've told my team which insurance, we will apply for it. Also, when it's time to enroll for your insurance next year, you can also do a quick check and see which insurances that you're eligible for am I on the plan for, and then we can work it out. A third thing to keep in mind is that you can go out of network. So some insurance plans allow out of network benefits, and you might be able to see me that way. Fourth option is old school cash, and so you can see me and pay for the visits in cash. Lots of different ways for us to connect. Holler 614-304-3444. That's actually my clinic number. I'm going to type it in the chat. Boster Center for MS, 614-304-3444. And if you guys haven't seen our website, please check out our website. It's a pretty cool website, I think. I'm a little biased. It's bosterms.com. So take a look at that and let me know what you think. Dominic is on from Istanbul. That is really, really cool. And Jim's calling in from Michigan's Upper Peninsula, up in the UP. That's awesome. This is so much fun, guys. Let's take a question from Jason, who writes, thank you for everything. You're welcome. You've been an inspiration to so many people. Without you, I wouldn't be where I am. Wow, that makes me feel really, really good. Jason, thank you for saying that. It's no secret. I talk about it on here a lot. I decided to be a MS doc when I was a kid because my uncle was very poorly cared for with his MS in this town by doctors in this town. And I told my mom that I would learn to do it better. And the fact that I get to practice MS in my hometown and make sure that other families are better cared for than my family was is important to me. But I also want to be able to extend my reach. And so YouTube is a great way to do that. You just gave me this amazing compliment and you're over in Wales. And that just fills my bucket full of joy that I got to help you out. And I don't even have the honor of getting to meet you. So Jason, thank you for those kind words. It means the world to me. What else do we have cooking? So here's a question. Someone's writing in from India. Surjit writes in from India and says, I'm on Avenex since last 10 years, ever since I was diagnosed with MS, still have side effects. Is that normal? Should I change? My MS is stable, recently my TSH level. So what do you do if you're on a medicine and you're stable, but you're not tolerating it? Is it fair to upgrade or switch? And the answer is yes. Taking a shot where you give yourself an injection once is palatable to most people. But taking a shot once a week forever is hard, and it becomes harder over time. And so if you're having flu-like symptoms, for example, you take your Avenex and then you're in bed for 2 days with flu-like symptoms, I think that's abominably yucky. And back in the ancient days, the 90s, we would have to beg you to do it because we didn't have a lot of other options. However, today, 2021, there are other options. And so we could make a switch to something that will work at least as well, probably better, but not have the same side effect profile. And I want you to live your best life despite having MS. And I want you to not be miserable while we're treating you. And if the shot is making you have side effects 10 years out, I would definitely talk about making an upgrade or a switch for sure. So Erica R writes in, are constant fluctuating fevers common in people with MS? No. Or totally unrelated? It's very likely unrelated. MS can affect temperature, but it's not common. It's actually very uncommon. And so I would be looking elsewhere in addition. What else do we see here? So do lesions have to be periventricular or juxtacortical only? No. So there's lots of different locations where you can see lesions on the MRI. Spinal cord, the base of the brain, the infratentorium, the periventricular white matter, and juxtacortical white matter are the most common locations. But you can have stuff in other places. Now, I have a couple videos on my channel where I go over MRIs. And if you haven't checked those out, definitely look at those MRI videos. I pull up MRIs where I've de-identified, so you can't tell who the patient is. And then I read the MRI for you and show you how I think about it. All right, what else do we have going on? Matt is still being super helpful. Matt, thank you for all of your help as moderator today. And we have a question from Harry M, who says, "Hi, Doc. Any implications for IVF aside from limited drugs during conception pregnancy?" I think that's outside my purview as an MS neurologist. Moon, looking for the sun, writes, "Hey there, I'm Sarah from Italy." Well, hello, Sarah from Italy. "I wanted to know if it makes sense to take a disease-modifying therapy while having 0 symptoms and not many lesions. I'm afraid of the side effects while I'm totally fine." That is a great question. So Moon, looking for the sun. Number one, I hope you find the sun. Number two, Italy is an amazing place. I've had a couple of vacations in Italy that have been to die for. So thanks for writing in from Italy. And most importantly, you must be on a DMT, 100 million %. DMTs are not to make symptoms go away. DMTs are to prevent future attacks. So let me use a birth control analogy. So Moon, looking for the sun. If you have 3 children and you start taking oral birth control pills, you still have 3 children. They don't go away, all right? So you could take birth control all day long. Your kids are still there. Taking birth control does not remove the children that are already born. You're taking birth control not to remove your 3 kids, but to prevent a future unplanned pregnancy. And my joke is, if you're curious why you're taking birth control, go hang out with your 3 kids and you'll be reminded. So if you're not having a lot of MS symptoms, congratulations, that's fantastic. You take an MS medicine not to make old symptoms better, because that doesn't do that. You take an MS medicine to prevent new symptoms, new attacks, new brain damage, new spinal cord damage from occurring. It is absolutely the right time to take a DMT. And I would 100% strongly enforce the idea that you should do that. Very good question. Thank you for asking it. MS Water Challenge. So Brenna is from Denver. Hello, Brenna. Hey, Dr. B. I'm on my 2nd year of Mavenclad. My question is, can Mavenclad cause long-term unresolved nausea? I don't think so. The impact of Mavenclad is short. It's in your body for like a day after you take it. So if you take 5 days in a row, by day 7, it's gone. And there should be no lasting effects because 7 days after you've taken that first pill, you can't even find it in your body. I would not expect to have a long-term symptom like that. And I would definitely look elsewhere as to why I'm having that symptom. You can have nausea for other reasons, and MS can cause nausea. Let's see. Fabiel's online writes, I suffer a lot with pain. I can't tolerate more than 100 milligrams pregabalin, which is Lyrica, because it spaces me out too much. I'm terrified of gabapentin, so that's Neurontin, because of weight gain. What are my other options? So there are a lot of options. I can think of probably 25 different neuropathic pain medicines. There's a bunch of medicines like the ones that you just described that were invented for seizures, and they work to treat pain, like topiramate, which is Topamax, or oxcarbazepine, which is Trileptal, or carbamazepine, which is Tegretol, or what's another good one? Lamotrigine, Lamictal has properties that treat pain. Keppra, sometimes people feel can treat pain. So there's a lot of drugs there. There's also a bunch of antidepressants that have been shown to treat pain, like Cymbalta, which is duloxetine, or any of the tricyclic antidepressants, like Elavil, which is amitriptyline, or Pamelor, which is nortriptyline. So there's a host of medicines. I think I just named like 8. And I could keep going for a while. But the point is, you go back to the doctor and say, hey, this stuff's not working. I need something different. And then we have to find a drug that works for you. So Shelby writes, is there any way to build up your immune system on Ocrevus? Well, you have to remember that MS is a problem where your immune system is too built, right? It's too hyped up. And so you have to be careful about wanting to rebuild your immune system. There are medicines that they give cancer patients to make them make more white blood cells. And that would be a really, really bad idea in the setting of MS, because you could trigger an attack. The reason that Ocrevus is effective is because it suppresses part of your immune response. Now, I assume that you're asking in the question or in the setting of like a COVID concern. And one option is to wait. So if you wait long enough, you will repopulate your B cells. The downside of that is that you're then not protected for your MS. So Neil writes, any suggestions for processing issues? Seems like I never recover from it, lost my ability to drive. So if what you mean is thinking and memory, this is very common in MS. The most common thinking and memory problem is difficulty with multitasking, thinking under pressure, thinking under time constraints. And that's kind of reflective of prefrontal cortices, like stuff up here, executive functioning. And there's ways of retraining your brain through speech pathology, cognitive rehab. And there's medicines that you can take to trick your brain into being more awake, which is a really great thing. So I would check out my YouTube playlist on Cognition right here on this channel. I've got a bunch of videos where I talk about that. This is amazing, guys. There's 191 people that have joined us online. Thank you, each and every one of you. If you like what's going on right now, give a thumbs up. You got to jump out of the chat, hit the thumbs up button, and jump back in the chat. I wonder if we can get that up to 200. I've never had it up to 200 in the 6 years that I've had this YouTube channel. That would be like a colossally cool thing. So I wonder if you guys are feeling the love and we can kick that up closer to thumbs up 200. Let's see if we can do it. Meanwhile, let's answer a couple more questions. Anne writes in, can you do anything to help speed up discovery of remyelination or myelin-inducing therapies? So you could do some things like raise money and then give the money to some researchers who are working on that. And that's actually like legit. You could volunteer if you have MS to participate in one of those trials. That's probably the most impactful way that you could help. I think that other than that, we're forced to allow science to unfold and think, oh my gosh, we did get 200 thumbs up. That's amazing. Thank you guys. Wow. But I think that remyelination is within striking distance. I think we'll probably have a remyelinating drug, if I was guessing, in under 10 years available on the market. There's a lot of trials going on for remyelination, and you might just do a search and see which centers near you are running remyelination trials and see if you can participate and kind of stick it to the disease by volunteering to help us figure that out. That would be really, really meaningful. So Paul writes, I dig the artwork on your wall behind you. Thank you. So that is a portrait that my grandfather drew. So my grandfather was quite an artist, and so he drew this lady. I sort of think of it as my grandmother because it kind of looks like my grandmother, but I love it, and I love having it in my office. Let me stick it back up here. So that my grandfather, Irv Levy, who was my uncle's caregiver, his son, my Uncle Mark, had multiple sclerosis. And I learned from my grandfather at a very young age what it meant to care for someone who has MS. I learned what it meant to help someone with a catheter or disimpacting someone or helping someone eat or wiping their face because they couldn't when I was a small child. And I learned what it meant to care for someone else from my grandfather, the man that made that painting. So that's a really special painting to me, and thank you for calling it out. That makes me feel really good. Sometime we'll do a live stream where I'll walk you around the clinic. I didn't have the foresight to grab a camera that would work like that because I'm on my computer, but I want to show you because I have a lot of my grandfather's artwork, and it would be really, really cool to share that with you. So thank you for calling that out. All right, what else we got here? I've got AVJ Kids who writes in, hey, Dr. Boster, it's Steve from Long Island, New York. Hey, Steve. What do you think of Botox injections to help with spasticity? I think Botox is awesome. So spasticity, as I talked about earlier on this live stream, is a situation where your muscles misbehave and they fight with each other. So the muscles that want to do this are fighting the muscles that want to do that at the same time. And that results in three things: a limb that's hard to bend, spasms, or cramps. So a cramp is a visible contraction of the muscle, like a Charlie horse that hurts, and a spasm is when your leg or arm are bouncing. Now, when you have spasticity, the first question is, where is it? So if you only have spasticity in one area, a focal spasticity, then we try to use a focal treatment, like Botox. Botox is a toxin that you inject into a muscle, and it poisons the muscle. So you don't want to inject too much, just a little, to poison the muscle a little, so that these muscles, which are over covering these muscles, can balance each other out. All right. So if you can poison the one that's too strong a little bit, then they're in balance, and then you can move more easily. Now, sometimes people don't have focal spasticity. Sometimes both arms and both legs, or one arm and one leg are all spastic, and you can't Botox that much. So if you're dealing with a regional or a diffuse spasticity, then we use therapies like oral medicines like baclofen and Xanaflex, or baclofen pumps. And we still find value in Botox. I'll give you an example. Let's say someone has severe spasticity in both of their legs, and baclofen doesn't work, and there's not enough Botox available to Botox everything. So we put in a baclofen pump, and we dial up the baclofen pump, and we take care of the spasticity beautifully, except for in the feet, because the baclofen pump didn't help the feet adequately. Then we go back and we Botox the feet. And the combination of the baclofen pump and the Botox together is money. So that's a really good question. I am very into managing spasticity. It's one of my clinical interests. And we do Botox here at the Boster Center for MS, and we do baclofen pumps and spasticity management for our patients with MS, because upwards of 70% of people with MS can develop difficulties with spasticity. So we've got another question from Vanilla 9999. I have myasthenia gravis and cervical dystonia, highly suspect MS. Do you see them together much? No, actually. So myasthenia gravis is an autoimmune condition, all right? And MS is an autoimmune condition, but they're on different sides of the nervous system. And there are case reports where someone has both, but that's very rare. It's not very common. So I got a question from JCON, who writes, Tysabri going on 3 years, JC virus positive, low antibody count with regular blood work. At 2 years, did 2 months shot washout, then back on rest of the year. Repeat every year. Thoughts? So what I'm hearing is somebody with MS is on Tysabri. Now let's take as a foregone conclusion that you're responding well to Tysabri, that you're not having attacks, that you're not having new spots on MRI, that your brain's not shrinking at a faster rate than expected, and your exam's not getting worse. All right, so let's take that as a foregone conclusion. Now, if you're JC virus antibody positive, there's a slight increased risk of infection, of PML infection. And when I say slight, I mean slight. So 3 years on drug, you may have a risk that's 0.01%, which is a really small risk. And it's not my right to tell you that's okay, but it's also not my right to tell you that's not okay. What I think we have to do instead is we have to show you the statistical risk profile, like the actual numbers, which the manufacturer collects and puts out for us. And then you have to decide whether you're comfortable with that risk profile. Would I be bothered by a low positive? No. And as long as you accepted this small statistical risk, we could keep on keeping on. One of the things that we do very commonly in the United States with people on Tysabri who are JC virus positive and want to stay on is we go from every 4 weeks to every 6 weeks, which decreases the risk profile. So that's very, very helpful. And it's been shown to decrease the risk of PML. Can we get some flames going, guys? Miguel had a great idea. There's some flames in the chat. Go ahead and flame up the whole chat for me if you don't mind. Throw some flames in the chat. Let's get the whole thing flamed up. And then I'm going to answer a couple more questions. Could we get some flames in the chat? Somebody's going to help me out. There we go. So Matt knows, or so MD Hewitt's in on it. And Jen McGraw is very, very helpful. A Pepper has got some flames. See if we can flame up the whole chat one more time. I really appreciate the interaction, guys. It's super fun for me. Let's get flames across the whole chat, and then we'll jump into a couple more questions. We're almost there. We've almost, yeah, look at that. Here we go. Nancy is helping out. Thank you, Nancy. And I've got a bunch of people that are all flaming up the chat. Chrissy is helping. Vanilla's helping. Linda's, hey, Linda's helping. Mandy's, all right, thank you, guys. We did it. We definitely have flamed up the chat. I'm trying to get all of these to show. Some of them are being blocked. Look how fun that is, guys. Thank you all very, very much. That was really, really fun. This has been an awesome, awesome live stream, impromptu. By the way, starting next month, I'm going to be doing a scheduled monthly live stream on YouTube. So this exact platform, I'm going to be doing a scheduled live stream. I've told you now for a few years that I do a cruddy job of planning my YouTube live streams, and I'm sorry for that. But I have a team member at the Boster Center that's going to be helping me, and we're going to be scheduling live streams. Now, what that means is that we are going to let you know months ahead of time the schedule. So we'll let you know it'll probably be like the last Thursday of every month, but we'll clarify that. It'll probably be Eastern Standard Time, sometime after work, like 6:30 or something like this. And we'll let you know ahead of time. I'll put it in the community here on this channel. I'll include updates letting you know that it's happening on Twitter and on Facebook, and we'll put it on our website. And this is going to be a scheduled thing. I'll at least do an hour, probably 2. And during that time, I will deliver a didactic lecture, like when I make videos each week, and I'll answer Q&A questions. And I'm really excited about it. So that's coming soon. We're going to have a scheduled monthly live stream. Now, I'm still going to jump online the way that we have been because I love these impromptu Ask Me Anything opportunities. It's super fun for me. I love reading and answering your questions, and I love this growing global online community. Let me answer one more question here. I've got a question coming in. Hi, Doc, from LA. I'm thinking of getting nerve ablation for my debilitating MS hug from pain management doctor. Thoughts? So MS hug is nasty, nasty, nasty. It can be extremely painful, and it's very hard to treat. And so I'm glad that you're working with a pain doc. And I assume that you've had other discussions of injections or spinal cord stimulators. And if you're going to consider ablating the nerve, I don't think that's terrible. Now, you may have permanent numbness along that rib, but I think if you had to choose between permanent numbness and the MS hug, you're going with the numbness. So we've almost been on for 50 minutes. I'm going to wrap up. I'm going to do another round through my infusion center and make sure that everyone back there is doing awesome and that my nurses are doing well. I want to thank all of you. This has been a fantastic addition to my Saturday afternoon, coming off of a really fun Saturday morning clinic. I couldn't have thought of anything else that I would rather do than jump online and interact with you. I want to thank Darla and I want to thank Matt, our moderators, who have been really helping out. And I want to thank all of you for asking your questions and for giving me a thumbs up and for flaming up the chat. Thank you. Thank you. My name's Aaron Boster, and until my next video or my next live stream or the next time I see you right here at the Boster Center for MS, be safe, take care, have a fantastic Saturday. I'll see you guys. Look for my video every Monday morning at 6 o'clock. Peace.